Thank you very much. They allowed me to share my slides. Can you hear me okay?
Yes, perfect.
Okay, great. So I wanted to introduce cranial ultrasound. This is a shift from the TCD that has been spoken for, since we don't do that quite often in the pediatric emergency medicine. So I wanted to share some of the things that we do here in pediatric emergency medicine for kids who are coming in. So I have no disclosures. So the objectives I want to go through, or I just want to introduce what pediatric cranial ultrasound that we do in the PTR and some of the probes and knob selections, and then introduce what you can find when you do some of these for skull fractures and looking at suture lines, as well as anything that's intracranial pathology that we may encounter in the pediatric ER. Sometimes we do see pregnant women who come through the pediatric ER, and then when we do from time to time do also some prenatal cranial ultrasounds, and then introduce other scalp findings. So the probes that we tend to use are linear probe as well as our phased array probes. There's really not a lot of role for a curvilinear probe since this is a much bigger structure for a small neonate brain. So the thing to really look at first when you're doing any type of cranial ultrasound for a neonate or newborn who may have encountered some sort of accident, whether or not they're dropped by their parents or they fell off from somewhere, and usually it's from a couch or a bed, and they may sustain a head fracture. Sometimes it can look very similar to suture lines. So it's very important for us to know where our suture lines are. So it's just for reference, we want to just indicate where the anterior fontanelle is and everything else from the coronal suture lines to the sagittal suture lines. So this is an example of what the suture lines, those are the example of what the suture lines look like. And they just seems like a little small break within your cranium that you can encounter. And to really know the difference between what is a suture line and what is a fracture line is really, you look for any signs of any hematomas around the area of trauma where the child may have landed. And your suture line should really be symmetrical. And you would want to be able to follow the suture lines up and down or from side to side. And you want to compare the exact area on the opposite side. If you think that there's a fracture there, and if you do not find anything similar on the other side, chances are it may be a fracture, but you don't want to also confuse it with an actual suture line. So here's an example of the right skull. And this is from a trauma, but whether or not if this is a suture line or is this a fracture, we don't know. And your best way to compare is on the other side of your skull in the same area. So this is indeed actually a fracture rather than a suture line. And so the study has been done as far as back as 2013 by Jim Sung and his group with Joni Rabner, looking at what is a fracture and how accurate it is using a ultrasound to detect fractures, fracture lines and then whether or not if this patient needs to have a CT scan. So in the PCR, we CT left and right. So in order for us to even prevent a CT which would be extremely helpful if we can. But then we also run into whether or not the patient actually has anything that's intracranial hemorrhage of any sort. So here's an example of what a fracture line looks like. So they tend to be sharp edge. You see that it looks like almost it's a oblique line with a sharper edge that's sticking out, although that may not always be true, but that tends to be what we see most often. And just on the side, you see a little area of the hematoma. So this is an example of what, and can also see what a what a fracture line looks like. And on top of that, you will see a hematoma, which will indicate in a bit. So here the arrow points out to the fracture line, and then here is the area of your hematoma, which is over the fracture line. And so this study has been done by others in the field, especially by Dr. Pari from Italy, who actually looked at whether or not the POCUS is accurate for the diagnosis of skull fractures in children who are younger than 2 years old. Because older than 2, they tend to tell you. They don't actually fall as much. Well, they do fall, but then they'll tell you where it hurts. You look at the area. Whereas for younger than 2, the patients who may be nonverbal, especially, sometimes they may be non-accidental or accidental, but they're not as verbal so to express where their pain may be. So they have looked in using POCUS to detect any type of any skull fracture, and they found that very high sensitivity, which is 90.9% indicated here with a good specificity at 85.2. So it's fairly accurate when you compare it to a CT scan for looking at positive fractures and positive CT scans. And so some things that we want to also look at is the location of the hematoma. To me, it doesn't really matter like what you call it. Is a hematoma, but sometimes it may matter just for the sake of looking at it. And then we'll take a look to see the membrane that's either over it's either like your galea or around the areas of your periosteum. So let's just break it down. So the caput succedaneum, which I can never pronounce, is just a boggy area of the hematoma right beneath your skin. It's right underneath your skin, but it's right above your galea. And the subgaleal hematoma is what we tend to really see more of, is underneath your galea, but really above your periosteum. So this is the area that actually crosses your any type of suture line. So as indicated here on this diagram here, it goes over your fontanelle, so indicate that it crosses the suture line. But where you have the cephalohematoma, it actually is within the periosteum itself, and it does not cross any type of any suture line or any type of fontanelle. So that's the difference. So here we have is a suture line that you can see, and we know that it's a suture line because it actually is a nice clean break, and then we can actually see sometimes the structures beneath it. And the cephalohematoma here that you can see, the arrow actually indicates that this is an area of the bone, and right above it, but within the periosteum is actually a hematoma. So this is a cephalohematoma. So with a subgaleal hematoma, you can see here the arrow indicates where the fracture is, that it actually goes over your fracture line. The same thing here also on the second picture. So to see where the, sometimes you can see the fracture line right there was indicated fracture, but your hematoma may not always be right over your fracture. And they tend to find in other studies that your hematomas can actually be on the not quite over it. It should be on the left side or on the right side, but not necessarily right over the fracture line. So you kind of just want to look around that area as well for your hematomas. So here is an example. If you can indicate, so what do you see here? Do you see an area that looks like an opening, and there's a little triangle underneath the opening, and then there's an area that looks like a hematoma. So the hematoma actually crosses over the suture line here. So we know that this is not a cephalohematoma because it's going over the suture line. So this looks like a fontanelle to me. And then what it says here is a fontanelle opening, subgaleal hematoma, because we know that this is not a cephalohematoma. So there's studies there that have looked into using POCUS to identify subgaleal fluid collections. And this is a nice case series that was done over from Yale, where they looked at different areas where patients are coming in with just fogginess or just increased frontal bossing, and they just don't know why. So when they actually did POCUS on them, they found all kinds of different pathologies, and which helped them to locate to indicate whether or not the patient actually needs to proceed with a CT scan. And in this case, this patient was subsequently diagnosed with an epidural empyema because they saw an area of swelling and then lifting of the bone when they were doing the POCUS. These two are other examples. The first one here, the same thing. They saw frontal swelling. And when they also did the POCUS, they saw there may be some subgaleal fluid. And then this patient was subsequently diagnosed with epidural abscess. And same happens to our figure 3 here with this patient that has some swelling as well, but they didn't find anything on the CT scan. So this is a pretty good use also of the POCUS for our patients here. So when I started doing this type of imaging in the pediatric ER, we don't do this quite often, but sometimes we do look for fractures, but I thought that would be fun just to take a look to see what's inside the brain, because we don't really do that often. And then our window that we use is either the anterior fontanelle or the posterior fontanelle. So here's us trying to look at using the linear probe, just looking to see what the architecture looks like on the inside. But I found that if I use a phased array, I can see a much broader area and wider so that it can give me a better indication of what's inside intracranially. Perhaps there might be a hemorrhage from the fracture itself. Okay. So we do see patients are coming in with either like increased ventricular sizes for intracranial intracranial size with shunting. And then here's one patient here that we see with enlarging cranial size. And we can potentially see whether or not we can compare the different sizes that's from either the previous CT or the MRI that was done with our findings here in the using the ultrasound. And again, here is another example of the increased ventricular sizes for our patients here. So this patient actually has swelling from an old shunt here that has been collecting the fluids here, pseudo Langone. And so there's another shunt that was placed, but it was just having increased swelling. So we wanted to see what was indicated. So as you can see here, there's a shunt there in this patient with the bogginess. And here's her intracranial ultrasound that you see here. And then you can actually even see the shunt on the lateral portion of this. And so that we were able to trace whether or not which shunt was it that was actually the culprit. Okay. And so there have been studies that were done to try to identify whether or not you can identify hydrocephalus in the PVR using POCUS with transcranial ultrasound. And here, so these are just landmarks that you want to indicate whether looking for these type of any images through POCUS. And they found that you can potentially with certain type of measurements, whether dilatations of either the third ventricles or the thinning of the brain. So basically for us in the PCR, this is pretty much a yes or no. Okay, yes, you have this. And then what are we going to do about it? We're probably going to do like a fast T2 MRI. Or if we do this enough, we can potentially use ultrasound to potentially use it to subsequently measure the types of increased ventricular sizes for patients who may be doing this more often. So they've also done studies where they looked at using the pediatric emergency medicine physicians and radiologists looking at head ultrasounds in the NICU. But I found that this is not as helpful because they're so good in the NICU. So I probably would just leave it for the NICU physicians as well as the technicians who does this on a regular basis. So for our patients that do come in who may be pregnant, we from time to time, we do encounter them to be within the second trimester. And this is when we actually do more of a dating, looking at the crown rump length, dating for the bipyramidal, because the crown rump length, actually the measurement can end after the first trimester. So to measure the bipyramidal diameter, which I'm sure you guys don't do as often, is that we measure from the outer to inner calvarium and also combine them with the head circumference. So this is an example. So we actually measure from the outer to the inner portion of your skull. And then you combine it with the head circumference, and you actually get a pretty good measurement. So this is pretty good dating for how long, what's the gestational age for the patient. And so it's been pretty good, but usually it's very more helpful after within the second trimester, but not so within the third trimester. So here's another example of your measurement with the head circumference with the bipyramidal diameter. So there are some limitations with this type of measurement. It's not reliable outside of the second trimester. And if you have twins, that doesn't work either. And if you have patients who have such as Zika or any of macro or microcephaly, the measurement will not also work for these patients. So other things that we do encounter for any type of any skull POCUS is that mastoiditis. Here's an example of mastoiditis and also an erosion of the bone that may occur. And also the epidermoid cyst, which is sometimes it's just fun to look at, but there's really, we just observe some of these cysts that occur in the ER. So in summary, our gap probably is that there's just still a lot for us to need to learn in the PZR about head ultrasound and POCUS. So I reviewed some of the applications that we see in the PZR, and then that to see that we may need to use it. We can use it for fractures, but we want to be able to differentiate it between suture lines as well. So it's helpful for pathologies, but it's really not a definitive diagnosis because sometimes that may be just useful just to do a fast T2 MRI. But if that's not available, we may just have to do the CT scan. However, the CT scan is additional radiation for our children. Limited studies in hydrocephalus, but I do see potential there in terms of subsequent measurements for hydrocephalus. And neonatal brain is a subspecialty that probably just meant for the neonatologist, and then we can assist in the PZR side. So, and then that's it. Thank you so much for this talk.